Thank you for joining the Ohio ACEP Informational Advocacy Zoom. I would like to thank our presenter and current Ohio ACEP board member and past president, Dr. Michael McCrea, as well as our Ohio ACEP resident board member, Dr. Megan Ladd, for joining us today and planning this presentation. So I'm going to go ahead and turn it over to Dr. Michael McCrea.
Hello, good evening. So thank you, Holly, for the introduction, and thank you, Dr. Ladd, for continuing this excellent webinar series for medical students and those that you joined. I want this to be informal. Dr. Ladd and Holly, if you could monitor the chat if there are questions, certainly we'll have time at the end. We're slated for an hour. I probably won't talk that long, but you never know, right? So I worked today along with Dr. Ladd. We actually worked together in the department. So who knows? This may actually go long. No, it won't, because I want to be respectful of people's time. So I'm just going to call this Advocacy 101, right? So how to get involved in advocacy in medicine, but more importantly, why you should be involved. And we'll go through some wins that we've had as a chapter and a college, maybe what some would consider non-traditional forms of advocacy, just to show that advocacy is not just the three branches of government, right? So I promise that this talk won't be your Schoolhouse Rock, how the bill becomes a law, although we could do that too, right? How it goes from House to Senate and back and forth. But I think when most people think of advocacy, they think of Congress, right? So they think of the Capitol, and all these pictures are actually pictures that I've taken on our advocacy trip. I want to consider myself an amateur photographer. Thankfully, we usually have pretty nice weather in DC when we go to DC and when we go to Columbus for our state advocacy day. So I think most people, they think of going to the Hill when they think of advocacy, or maybe even they think of the White House, right? They think of, we need to lobby the president or the executive branch. But really, for your day-to-day practice of medicine, all politics is local, right? What controls my day-to-day practice when I see patients is much more determined by what happens in Columbus at the state capitol than happens in DC. And I'll take that one step even further. What really determines my hour-to-hour practice and patient-to-patient practice is what is decided at my local hospital. So I work at Mercy St. Vincent's in Toledo, Ohio. And there are decisions that are made by administration or by other departments in the hospital, but I'm not going to talk about like that local advocacy. I am going to talk about what Ohio ACEP does and what National ACEP does as a college for the specialty of emergency medicine. But the reason that's important is, like Mad Eye says, right? You have to have constant vigilance, right? Because it's not just the House and the Senate or the president or the governor that make rules. It's actually a lot of executive branches that really don't have the checks and balances. I guess, I promise I won't do, Schoolhouse Rock. But at the federal level, CMS, right? The Center for Medicare and Medicaid Services, the Department of Health and Human Services, and then the Joint Commission that accredits hospitals. We just had a Joint Commission visit at our hospital, and there were some things that had to be fixed immediately within 10 days, or really bad things happen, right? And that's not subject to legislative oversight and judicial review. It's just like, y'all better fix this, all right? So, but at the state level, it's even more. And we, as Ohio ACEP, have to constantly monitor what's going on in the governor's office, what's going on in the House and the Senate, and then actual medical boards, like the state medical board could pass a rule that just says in 90 days, all prescriptions require this, right? And that's it. I mean, maybe there's a comment period, maybe there's not. Ohio Medicaid, we'll talk some examples about Medicaid in a little bit. And similarly, the Board of Pharmacy, right? They can just pass rules that say all pediatric prescriptions for opioids require written parental consent. Wait, when did that happen? Right? That happened like a couple years ago, just effective in 90 days, that happened. So an organization like Ohio ACEP has to constantly be monitoring all of this. And on our call, we do have Amanda Sines, who is our lobbyist. Wave, Amanda. There's Amanda. So, and she lets us know, because sometimes we need to respond immediately. And we have our executive director, We have our executive members of the board, the officers, the board of directors. We have a government affairs committee. And sometimes it's just the president's like, we need to respond to this, because there's this saying in politics that if you're not at the table, you're on the table. Okay. And for any Big Bird fans out there, I'm sorry, but this was just too good not to include. All right. So that's kind of laying the groundwork that really things can come from anywhere. And what you really want in advocacy is not just to be reactive, but also to be proactive, actually make changes for the better, as opposed to just trying to stop changes that somebody else is making. Okay, so I'm going to talk about a couple advocacy wins that we as a college or as a state have had. We're going to talk about food and drink in the emergency department. Start with something simple, but if you don't think it's important, you haven't worked enough shifts. We're going to talk about what we call merit badges in medicine, talk about procedural sedation, and then Megan has encouraged me to tell a personal story that I worked with Amanda on a number of years ago on House Bill 7 called the I'm Sorry Law in Ohio. All right, so not that many years ago, this would have been taboo, these pictures. These are fine real life examples. On the left, we have a resident eating what can only be considered an emergency medicine lunch, veggies, ranch, and Diet Coke. Right. And then on your right, actually an actual sandwich from the cafeteria. But only a few years ago, this would have been illegal. And if hospital administrators or, God forbid, any kind of regulatory agent had seen this, the hospital would have been cited, because this was a violation of OSHA and Joint Commission rules about food and drink. And you say, well, what's the big deal? Well, there's concern about contamination and infection, and, you know, please don't put the urine and the stool samples where the ranch is, right? But it actually got to the point that we, as a college, said, we need to have a policy statement on food and drink for staff in the emergency department, right? And it sounds silly, but this was life-changing for us, because now I can feel free. Of course, this was right when the pandemic started, by the way, if you note the date, April 2020. So that did cause some problems because you had to be masked and stuff like that. But what it says is that, okay, the staff may have limited access to proper breaks. Ask an emergency medicine resident like Dr. Ladd, what's a break? She don't know what a break is, right? She and I literally worked together today. And at some point, I think we ate, but maybe not some days. So it's important. And we got this passed, right? So ACEP lobbied, this was important to our members, and we went to the Joint Commission and we fought the fight. And now you can have food and drink at your workstation in the department. So you're welcome. All right. So that's a simple win, right? That's not what most people think about with advocacy, but you talk about making a difference in my shift or Dr. Ladd's shift or a medical student shift, or our nurses, right? It's not just for us, right? We advocated for everybody. So, all right, let's talk about something maybe a little bit more serious. So for those that are medical students, you may have taken a BLS class or actually taken ACLS, which is Advanced Cardiac Life Support, or PALS, Pediatric Advanced Life Support. And then once you get into your emergency medicine residency, you take Advanced Trauma Life Support, and then you take neonatal resuscitation. And right, we call these the medical merit badges, right? You got to show up to the course. And then just like the Boy Scout that I used to be, I was never an Eagle Scout. I didn't make it that far. You get your merit badge. So the one I specifically want to talk about is trauma. Right. So we get traumas. This is in our old ED, right? This is not an uncommon picture in a trauma, penetrating trauma. Obviously got a chest tube, dumped a bunch of blood on the floor. And when you're a brand new emergency medicine intern or a surgery intern, you have to take a course called Advanced Trauma Life Support, right? And it was kind of a thing that if you worked at a trauma hospital, that you had to stay current with your ATLS, even after you finished your residency and you passed your emergency medicine boards and you were board certified, right? And it's a one-day course and it costs over $1,000 for an attending. And I just don't want to give up a day off to go take a course that I don't need to do because I'm board certified and I know how to take care of trauma patients, okay? So a number of years ago, the California chapter wrote a council resolution, and I'm not going to talk about council today, but briefly, council is the parliamentary body of the college that passes and debates resolutions to guide college policy, right? So policy statements come from council resolutions. And they said, we want to look, as the California chapter, we want to look at Trauma Center Certification Task Force. And the spirit of this resolution fundamentally changed when the college got into it and actually started working with the American College of Surgeons, right? So that's the surgeons professional organization that certifies and accredits trauma centers around the country. And they actually came up with this clarification document in 2016. I can't believe this is 7 years old. Thanks, COVID. And the bottom line is, if you are board certified in emergency medicine by the American Board of Medical Specialties, so that's ABEM, right? So my residency training, the American Osteopathic Association, if you go to a DO program, or if you're from Canada, the Royal College of Physicians and Surgeons from Canada, that's all you need, right? So I never have to take ATLS for the rest of my life, thank God, because I know how to take care of trauma patients, right? And that doesn't seem like a big deal, but that's a really big deal, okay? The only thing is you have to have taken it once, right? And we all take it when we're interns. It's like month 1 of residency, and that's it. And once you finish your residency, you pass boards, you're good. And so every year, usually about 1 year after graduation, we'll get an email or a phone call or a text from one of our former residents at St. B's like, hey, Dr. McCrea, can you send me the surgeon thing that I don't have to take ATLS anymore? And I send them the document that I just showed you. And they're like, oh, no, that's your society's like, no, that's what the surgeon said. We don't have to do this anymore. So ACEP also has clinical policy statements about just the other merit badges. They didn't call them that in the policy. They called them short courses. AAM, I know this is an ACEP talk, but AAM has similar policy statements as well. And actually, this got to the point a number of years ago, it's actually happened right before COVID, that the Coalition to Oppose Medical Merit Badges, what we call the COMB, was put together. And they said there is no rational justification to require medical merit badges for board certified emergency physicians who maintain their board certification, right? Our committed professional organizations provide the best opportunities for continuous professional development, and medical merit badges dismiss the quality of those educational efforts. What does that mean? Right? A 3-year emergency medicine residency, becoming board certified and doing your maintenance of certification is way more detailed and comprehensive than a 4-hour online every 2-year renewal course, right? That's the point. And this was actually signed at the time by all of the presidents of all the emergency medicine organizations. And I can tell you it's not very often in EM that all of these organizations get together and agree on things. So real life example, I just recently got re-credentialed at one of our sister hospitals out in the community, and they said, Dr. McCrea, you need to send in your stuff. And I was like, no, I'm not going to. Well, you have to take the course. I don't want to. And I'm actually an instructor, which is the irony, as Megan knows. I was like, no, I'm not current, and I'm not going to take it. And here's the reason why. And they said, okay, because, they needed me to work there. But without that backing from our professional organizations, I wouldn't have been able to do that. And I, again, would have had to give up days off and pay money to take a course that isn't going to teach me anything and actually dumbs things down compared to how I actually practice. So the last big one I want to talk about is sedation. So I would say more days than not, in our emergency department, if not every day, there is a procedural sedation being done for something, okay? Whether it's a pediatric laceration repair, a pediatric abscess drainage, or most commonly for an orthopedic procedure like a shoulder reduction or fracture reduction dislocation, or splinting, or just, gosh, I don't know, we got to get this person through CAT scan and we don't want to have to intubate them like we did when I trained. So we want to use medicines, right? And the big two that we care about are ketamine and propofol, right? So ketamine and Diprovan. But it wasn't that many years ago that one or both of these medicines were not allowed to be used by emergency physicians because a lot of hospitals classify both of these as anesthetics, right? And I did an emergency medicine residency, not an anesthesia residency. And I've dealt with this at every community hospital I've ever worked at where they say, you can't use this medicine. I'm like, well, but this is part of my practice. This is part of my training. I'm board certified in emergency medicine. Well, you can't use it here. Okay. What's the number for anesthesia so that I can call them to come in and do this? Oh, well, why don't we sit down and talk about that, right? So that's, again, advocating at your local level. And ACEP has a policy, procedural sedation in the emergency department. And this was actually just updated. And they said the NPO status has not been demonstrated to reduce risk of emesis or aspiration in the ED for procedural sedation, right? So what's that whole, right? You go into the operating room, you need to be NPO for at least 8 hours, preferably 12 hours, or anesthesia is going to cancel your case. So real life example, I was working at a community hospital and I had a kid with a nasty fracture dislocation that I tried once. I couldn't get it reduced. I didn't think I was going to be able to get it reduced. It just wouldn't stay. And I called ortho. He's like, yeah, no, I appreciate the call. Thanks for trying. I'll take the kid to the OR. But of course, it happened at recess after lunch. He had just eaten lunch. And anesthesia said, yeah, we'll do that at 8:30 tonight. So I told the orthopedic surgeon, like, I'll sedate him again if you come in and do it. He's like, wait, I can do this right now and not give up my entire evening? I'm like, yeah, no, I'll do it for you right now. Just come on in. And orthopedics was happy. I was happy. I got the patient out of the department. Most importantly, the parents were happy. And the kid didn't lay there in pain for 8 hours with a fracture dislocation that I couldn't reduce, right? And it's policies like this that actually make a difference in my day-to-day practice. This is the kind of stuff that ACEP does for you. And again, this is not a legislative thing. This isn't going to the Hill. This is working with our docs to make practice better for our patients and for us as physicians. And then the other thing is that a lot of community hospitals, anesthesia still run sedation, and they require you to take their little local sedation course. It was about 9 years ago, I was at a community hospital. They literally gave me a VHS tape and said, I needed to watch this. I said, well, first of all, I don't have anywhere I can play this. It's a VHS tape. And some of you may not even know what a VHS tape is, right? It wasn't even a DVD. It was actually a VHS tape from like the 1980s. It was like, I think sedation in the emergency department or just sedation in general has changed a lot since then. And then I was going to have to take their little like course. No, I'm not doing that. I'm not going to do that. So again, I'll just call anesthesia in when we need to sedate people. And so as medical director, I worked with the hospital and I had these documents from our college and from CMS about sedation. And we completely rewrote the procedural sedation policy that had not been looked at in over 2 decades. Okay. So again, that's local advocacy, not what people always think about. And ACEP does actually support you, right? It's always nice to have a card that says I'm a procedural sedation expert and a cardiac resuscitation expert and a trauma expert. Now, I fully admit that a local hospital can say, what the heck is this, right? We're not accepting that. That's not from the American Heart Association or the American Trauma Surgeon, but it's something. And so I actually submitted these to our local Mercy hospital and they're like, man, it's a card. Okay, we'll take it. So that's great. All right. The next story, I'm going to slow it down a little bit and give you an example. And it's hard to talk about this because I don't want this to seem like a humble brag. But Megan really wanted me to talk about this, and so did Holly and Amanda. And if you think that one person can't make a difference, remember what JFK said. One person can make a difference and everyone should try. All right. So House Bill 7. So this was to change the apology statute in the Ohio Revised Code. So this is, I think, what most people think of as advocacy, actually trying to change the law. All right. So the apology statute at the time, and this was 7 years ago, was written, and it was modeled after legislation in other states that said to encourage prompt communication between the physician and the affected patient, evidence of statements by the healthcare provider that communicate apology, sympathy, commiseration, condolence, or compassion cannot be admitted in evidence. All right. And so what that meant was that if I took care of a patient and there was an adverse outcome, either the patient died or they had an adverse outcome, that per the apology statute on the books, I was allowed to go to that patient or their family and say, I'm sorry. Okay. In real life, that never happened. Okay, because it's very hard to sit a family down or a patient down in real time or soon after and say, I'm sorry, I express sympathy and compassion and condolence, but not say anything else about what happened, right? And so that was important because it would say that you couldn't introduce that in evidence in a liability case, so a malpractice case. But in real life, and the reason I wanted to change the law is this actually happened to me. And that's a different talk for a different day. about a malpractice case I was involved in that from when I took care of the patient to when it was resolved lasted 44 months. We wanted to be able to say a mistake was made, or we made an error, and that also would be inadmissible. And so Amanda knew that this was a personal cross of mine, that I'd been involved in a terrible case. Patient was transferred from another hospital to our hospital, and I won't go through all the details. And a very unexpected death occurred, right? Didn't really know what happened. And I very clearly remember in the days after being told by hospital risk and hospital attorneys and our own attorneys, right? Because I work for a group that contracts with the hospital. Don't talk to anyone, right? And all I wanted to do was say I'm sorry and meet with the family. And I was advised not to because it would expose us to risk. And that wasn't right. Fast forward 44 months. We're 3 weeks away from trial. And at the pretrial hearing, I'm sitting in an empty courtroom with the patient's mother, who I've not seen in 44 months. And for better or worse, we just started talking. And my attorney came out for meeting with the judge and said, "Mike, what are you doing?" And I looked at my attorney. I said, "For 4 years, I've told you I just want to talk to her." And he said, "Okay." And then her attorney came out from the judge's chamber, and he was really upset. And I said, "We just want to talk." And I was dismissed from the suit that day. And over the next couple of weeks, through our attorneys and then directly, we actually exchanged some emails, and I actually met her and her husband because he wasn't there that day. And she said, "I wish that people could have talked the way we did. I think it would be better for everybody." And I said, "This has to change." And so on a random day in Columbus, at an Ohio ACEP Advocacy Day, Amanda, our lobbyist, knew this story and introduced me to, at the time, Representative Cupp, who was a past Ohio State Supreme Court justice and was in the House and was interested in pursuing liability reform. And we're literally standing there in the lobby of a hotel, and we just started talking. And he said, "I think that there's something that we can do about this with your story." And so he wrote a bill. And after a number of times, right, because if a bill doesn't get through a General Assembly, you have to start over. Amanda's smiling, I think over 3 General Assemblies, right? But my partners were amazing. And sometimes I had not even 24 hours notice that there was a hearing. And my partners covered me and said, "We got your shift, go to Columbus because we know you can do this." And I testified before the House and the Senate Judiciary Committees. And we ultimately got it passed, and the law was changed. And it was through my involvements and the support of an organization like Ohio ACEP that could happen. But that was one physician who wanted to take a personal experience that was absolutely awful and I would never go through again or ask anybody to go through. But the silver lining was I made a difference, and I know other physicians that have benefited from it. And without Ohio ACEP and without our presence and respect in Columbus, and Amanda, our lobbyist, and Laura, our executive director at the time, and the support of the board and the Government Affairs Committee, that wouldn't have happened. And so if you think you can't make a difference, you're wrong, because they want to hear from us, right? And again, this is, I'm not trying to brag when I say this, but to hear the bill sponsor talk about my testimony on the floor of the House when asking for a vote is one of the coolest things that I've ever had happen in my professional life. I have the video somewhere. We don't have time to play it today. And to hear him say that this needs to change, not just for the patients, but for the doctors too, right? Because I went through it too, even though nothing happened to my family. So that's why advocacy matters, right? That's why your membership matters, is that you can make a difference. To think you can't make a difference, so that an organization can't make a difference, you're wrong, because all you have to do is show up and tell your story. And we have the best stories, right? As one of my mentors said, the show was called ER for a reason, right? It wasn't called dialysis or cath lab, right? It was called ER, right? When we go to Columbus, when we go to DC, all we have to do is tell them a story and we have their attention, right? We relate it to a patient, and we don't even have to make it up, right? Because I'm not that creative. I just tell them a story. So that's just one example. Unfortunately, at the time, the governor didn't do bill signings. So I didn't get to go to that bill signing, but I did get to go to another bill signing. This is with former Speaker Rosenberger of the House, that I was able to go to a bill signing and on a piece of legislation for opioid legislation. And we happened to be in Columbus. It was our annual meeting. We didn't know what was going to happen. And Amanda said, "Hey, there's a bill signing today. Do you want to go to that?" Yes, please. And I got to, watch him sign the bill. I still have the Sharpie. It's up there that he gave me that he signed our bill with, that we advocated for. So that's probably professionally one of the greatest things I've ever been part of. And even my kids, right? They were like, "Wow, Daddy, you got to go and meet and change the law like we learned about in school." I did. And you could too. If there was a personal something that you're passionate about, we are an organization that can help with that. I want to talk about a piece of current legislation that Ohio ACEP was working on, House Bill 99, the prudent layperson standard. What the prudent layperson standard is this is how I explain it. If you were walking down the street and you asked 100 people Family Feud style, is this an emergency or is it not an emergency? If the average person says yes, then that should be covered, right? It should be covered by insurance and should not be deniable by insurance after the fact, right? And you think, why do we need legislation like this? Well, because what insurers want to do is, so I'm a 45-year-old guy, a little overweight, and I'm in pretty good shape. I work out a lot. I don't smoke, but I got a family history of heart problems. And on the weekend, I like to, eat wings and drink beer. And on Saturday night or Sunday morning, when I have really bad chest pain and I go to the ER and Dr. Ladd sees me and orders some blood work and an EKG, and, after a couple hours comes back and says, good news, Michael. You just need to hit it a little less hard. You're not 20 anymore. You've got some heartburn. Thankfully, you didn't have a heart attack. And she discharges me. And what's her diagnosis, right? It's GERD or reflux. And then the insurer later, I have insurance. I have a job. I actually have pretty good insurance. And they say, "Oh, you went to the emergency room for heartburn? Oh, you should have just taken some Tums and seen your family doctor." And they deny the claim. And now I'm stuck with the whole bill, right? And Dr. Ladd's expensive because she did a really good job, right? She ruled out an emergency medical condition as required by federal law. And we don't know that I don't have an emergency until she does the workup, right? Because I'm not good enough to look at somebody and say, "Yeah, I don't think you're having a heart attack. You can go," right? I got to do the tests. And that means x-rays and labs and EKGs and repeat vital signs and several hours in the ER and maybe some medications, right? And that adds up. So that's why we need this standard, okay? It would also require insurers to perform a medical review by a physician, not a coder who may not have any medical experience, before they either deny or downcode. It's like, well, I don't want this to be a billing and coding lecture. It's like, well, we're not going to give you a level 5 visibility. We'll give you a level 3, right? We'll give you a little bit of a bone, but we're not going to pay the whole thing. And it would also, most importantly, require patients to get some education about what their actual coverage is, all right? And here's Dr. Brian Graham. This was just a couple weeks ago on May 10th. President of the chapter currently went down to Columbus and testified on behalf of this bill. And you say, Dr. Ray, I can't believe that this is a thing, right? This can't happen. Well, it actually did happen in Washington State. So Washington Medicaid, this was about 10 years ago, created a diagnosis list of 700 diagnoses that were going to be denied for ED visits, including chest pain and vaginal bleeding in pregnancy, right? Said, those aren't emergencies. We're not going to cover them. They should follow up with somebody else. Also, it was kind of like 3 strikes, you're out. Any visits over 3 in 1 calendar year, no, you went to the ER too much. We don't care what the 4th visit was. We're not going to pay for it. And Washington ACEP, Washington chapter, said, you can't do that. That actually violates federal law, EMTALA, again, that requires that every patient who presents to the emergency department be evaluated and screened for an emergency medical condition. All right. And so this actually got a lot of press, as you can imagine. And the only recourse they had was that Washington ACEP sued the state in court. And they won. They actually won. And then what's even better is that wasn't the end. That was just the beginning. And Washington ACEP and Steve Anderson and Nate Schlichter and their board actually worked with the Medicare or Medicaid department in the state and saved a significant amount of money for the state, because that's why they were doing it. They were trying to save money. And they did that, and they actually helped create information exchanges. This was like pre-Epic and Care Everywhere, that you could see that a patient was at another hospital and get those records. And they did this. They worked on this together, and they ended up saving the state significantly more money by increasing access to care and getting the patient the right care at the right time in the right place and sharing information, as opposed to just saying, after the fact, we're going to deny all these claims, right? And that's the power of advocacy. And here it is now, I guess 12 years later, it's 2013, and we're still trying to fight that in Ohio, right? Because it's a state by state thing. All right. So these are just a couple of examples. So again, you say, what can I do, Dr. McCrea? What can I do? Well, what's the most important thing you can do? If you're not registered to vote, please get your phone out and scan that QR code. I hope it works, because I worked really hard to make sure they were the right ones, and register to vote, okay? Because if you actually get involved and you go to meet with a legislator, I guarantee you the first thing they do before you come in is just check to see if you're registered to vote, right? So this is public access. You can type in my name or your name and where you live and see if you're registered to vote. It's like, okay, Mike McCrea, this guy's coming. He's registered to vote. And then they can also actually see like your voting history. Are you just a registered voter who doesn't vote, or do you actually go vote, right? Because if I'm meeting with a legislator in Columbus or in DC, and I'm not registered to vote, that means I can't vote for them, right? And they're already thinking, who's up next at 7 o'clock? All right, we got somebody else coming in. They're registered to vote. So maybe we'll give their issue. And there's a real chance that they're arguing and lobbying for the exact opposite of the same thing you were. When we were in DC 2 weeks ago, all day, we're walking around DC and we see CRNAs with big badges, CRNA. And what do you think they were advocating for? Independent practice, right? And I could talk a whole lecture about independent practice, but we won't do that. All right, so register to vote and then actually go vote, right? With early voting and absentee voting, there's no excuse. I'm a medical student. I work at the hospital from 4 a.m. to 12 p.m. and I'm there every day. I get it. You can still vote, right? You can still vote. The other thing is join an organization. If you're on this call and you're not a member of ACEP, great for finding us. I'm glad that you did. But emergency medicine organizations can be a little bit like alphabet soup. So I'm going to kind of tell you about them. So we are ACEP, right? So we are the American College of Emergency Physicians, Ohio ACEP. Yes, I even put up our friends to the north. Every state has its own chapter. And then EMRA is the Emergency Medicine Readiness Organization. If you're a DO graduate, you can also join ACOEP, small organization. They also have a resident organization as well. There is another organization, it's about 1/10 of the size of ACEP, called AAM. I am a member of them as well. I just haven't done anything nationally with them. And they also have a Great Lakes chapter. You look at the map, that's like old school Big Ten, the Great Lakes chapter. And then there's academic organizations as well, but they don't really do the advocacy. The other thing is actually find out who your elected officials are. You can just Google, find your senator, and this will pop up. These are Ohio senators, right? We just got a new one, JD Vance, because Rob Portman retired. Sherrod Brown's up for re-election next year. It's going to be a heck of a race. So that's how you find out who your senators are. You can Google, who is my congressman, right? And if you're not sure, you put in your zip code. I found out at the polls that my district changed last year because of redistricting. Wasn't real happy about that. I actually thought there was like some kind of problem with my ballot. And I was like, oh, literally my street, the north side of the street that I live on is one district. The south side of the street is another district, the district I used to be in. Yeah, but that's okay, right? So find your representative. So I'm actually in Marcy Kaptur's district now. I don't know if you can see my cursor. My house is literally right there. I used to be in this district and now I'm in this district because I live on the north side of the street. All right. But once you're a member of Ohio ACEP, we make it very easy for you to find out who your elected officials are. You go to our advocacy page and you can click on find your elected officials and you put in your stuff and it will tell you who your elected officials are, right? So there's the Senate and the House district, and you just put in your address and it will tell you who your people are, right? So my senator is Senator Teresa Gavarone, and my representative is Representative Haraz Ganbari. So, and then once you do that, you could actually contact them, right? And there's lots of ways to do it. You could send them an email, and whenever we have a call to action, we make that very easy for you. Like we send that to members, we push it to them. I send it to all my partners. I put it in our residency group chat and hope that some people actually fill it out, and it's pre-populated. And you don't have to know really about the issue. We give you some language. It would be better if you made it personal, which I do. But it doesn't take that many contacts to an office to get somebody's attention. Probably about 5 to 10. And then every once in a while, like if we actually care about something, we'll just bombard an office. And I actually called the senator's office one day, and they're like, "Yeah, we've already heard about this 20 times today." I was like, "Okay, can I be 21?" And they're like, "We get it. Thanks. We will make sure that the senator knows about this." All right. Another time, I'll tell you that one in a second, right? You can use social media. Twitter, I know, is kind of going away, but a lot of elected officials still use it. If you want, you could send them a raven, right? So that's great for the Game of Thrones fans, or you can send them an owl for your Harry Potter. Or there's this old-fashioned technology of you could actually call the office, right? And ask to speak to either the member, or more likely their legislative aide, or if it's a national position, their health legislative aide. And a couple years back, there was a really important issue that was kind of in the lame duck session. So we literally had like 24 hours notice. And I actually called the Senate majority leader's office. And I said, "Hello, this is Dr. McCrea. Can I speak to so-and-so?" And they got me, the person right away said, "Yes, is there a problem?" I was like, "No, I just wanted to talk to you about Senate Bill, 123. He's like, "Oh, they said there was a doctor calling." And unbeknownst to me, the senator had just had a doctor's appointment and was waiting for some results. So that worked out really well. And I had their attention. I was like, "Well, I certainly hope things are good with whatever you're getting checked out. But while I've got you, can we talk?" And we talked, right? And that wasn't hard, right? I felt slightly bad that the poor staffer probably panicked that a doctor was calling after hours. But yeah, just call. And then maybe over time, when you meet your representatives at a day like Ohio ACEP Advocacy Day, and then you meet with them in the district, maybe you actually become friends. And I actually had to edit this slide so that I didn't show you their cell phone numbers. But I actually am like friends and Facebook friends, so it's serious, with both Haraz and Teresa. And you want to get to the point over years, and it's taken me a long time to get there. Haraz called me and he said, "Hey, Doc, it's Haraz." I'm like, "Yeah, what's going on?" I'm literally in my kitchen making lunch. He's like, "We're on our way to vote. Can you talk to somebody for me?" Sure. About what? And he's like, "The bill that we talked about last week." I'm like, "Oh." He's like, "He's just going to run this by you. He gets it better than me. Can you talk to him?" I'm like, "Well, I am on the board and I'm immediate past president, so I hope I'm authorized to do this." And I got it. And I'm like, "Well, it's not entirely everything we were hoping for." He's like, "Is it good?" I was like, "It's good. We'll take it." And we did, right? And that's how it's a good compromise, if everybody leaves a little unhappy and wanting a little bit more. We didn't get everything we wanted on surprise billing, but we got a lot. And that was literally my representative calling my cell phone on a lunch break on his way to a vote to see, so that he could say on the floor, "We have the support of the emergency physicians on this bill," right? So that's what you want. So that regardless of what the bill is, that they reach out to you, because if they don't reach out to you, they're going to reach out to somebody else, right? Here we were in DC. This was actually a picture from last May in Leadership and Advocacy. We happened to be in DC when the Dobbs leak happened. Regardless of how you feel about that decision, it's pretty amazing to see thousands of people outside the Supreme Court. I can only imagine like what the high school tour groups were thinking walking by. And that's what we do. It wasn't our issue for the day, but certainly became an issue for the college soon thereafter for protecting emergency rights and pregnancy. So if I've remotely inspired you and you are not working, and I realize it's like 2 weeks away, June 7th in Columbus is our advocacy day. It's part of our annual meeting. There's the QR code to register. You don't have to be an expert, right? You don't have to have been on the Ohio ACEP board for 13 years. All you have to do is care and show up, and they want to hear from you. Last 2 weeks ago when we were in DC, one of my groups that I was with we had a first-year resident from UH in Cleveland, and we were talking about one of the issues of the day as we were talking about ED boarding, right, and psych boarding. And as an intern, she had an amazing story. And she felt comfortable sharing that because it meant something to her to see this patient and what this patient and their family went through in her emergency department. And just the look on the staffer's face for Representative Kaptur is like, I can't believe that. And every single one was like, that's every day. That's every day. But she made it personal. And I told her when we left, I said, you're telling that story every meeting the rest of the day. She's like, I didn't know I could tell the story. I was like, that's what we need, right? We need to make it personal so that they understand that this actually affects patients, right? This is not just doctors complaining about things. Like, we're actually trying to make things better for our patients because, yes, we all went to medical school because we care, right? And we do want to make things better for our patients. So come to Advocacy Day. We're actually going to have a primer next week. And if you're registered, we'll get that information so that you actually know what the issues are. And then we actually are going to split up into groups, and we're going to put it all together, and you're going to get your schedule, and we're going to go meet in our state senator and representative's office. And if you're lucky, you might actually get to meet your member. This was a picture from a couple years ago. It's Dr. Eileen Baker on the left, and Dr. Greg Emel, one of my partners. They both work up here in Toledo. And both our senator and our representative came to a breakfast we had that morning, and we stood and talked about issues affecting patients in Wood County, right? And they wanted to hear from us. And that was one of the first times that I met at the time Representative Gabarone. She's now our state senator. And after that day, what do we say, right? It's not just one day a year, right? You want to build that relationship back in the district. And Amanda came up, and we were supposed to have a 20-minute coffee at Panera, and we were there for 2 hours because she actually wanted to hear about things. She drove up from Columbus when she was back in the district, and we met, and I gave her our Ohio ACEP coin. We just had this. This was our annual advocacy conference in DC. We have it every year. It's usually end of April, beginning of May. Again, you don't have to be a practicing physician to come. We love residents and medical students to get involved early and come. And I think that your stories mean even more because you're to already show that you're interested. And I know a number of our members have come as well. And we meet with the Senate. This is a meeting with Senator Portman's staff at the time on the right there, physicians from around the state talking about issues. Here I am again with Dr. Baker and Matt Sanders with Congressman Bob Latta, my former congressman now that I'm in a new district. Actually, he happened to be in the office, and they brought him in, and we got to take a picture because, you know, politicians like pictures with their members. And then here we are meeting with Marcy Kaptur and gave her the Ohio ACEP coin. So we actually created this. One of our Leadership Development Academy members a number of years back said, former military and big in EMS, and write the challenge coins. And he said, we need to have something that we can leave behind. And so we make these and we leave them in the offices. And it was pretty cool this year in DC to see our Ohio ACEP coin in the coin case for Representative Jim Jordan down by Columbus. We have a good time. We go to Columbus too. We try to, get out and see the sites. This is past President Gary Katz and past President Nicole Weidinger, two of my best friends. We just decided it was a nice day. We were going to take a walk down to the World War II Memorial, and of course had to take a picture in front of the Ohio sign. Once you're a member, we send these out every month. We send out our e-news. This was March. Got a president message. There's Dr. Ladd, writes a piece every month as our resident member of the board. We also send out government affairs. You can always go to the Ohio ACEP webpage and look for what we're working on currently. And then you can also, with National ACEP, sign up for advocacy action alerts. So you'll get it either as a text message or an email to contact your legislators about an issue. And again, it only takes a few hits a day, even if it's an impersonal auto email or text, for them to say, hey, there's something going on about, Senate Bill 123. And then the final thing I want to leave you with is a story. Again, back to the table, that if you're not at it, you're on it. So I had the privilege when I was chapter president to go to Columbus there was a potential surprise billing legislation. And I'm not a reimbursement person. I don't get billing. I don't do it. It's not my thing. And I remember kind of having imposter syndrome going into this meeting. Is like, I don't really know what I'm going to talk about. And Amanda and Laura, our executive director at the time, is like, just be yourself. I'm like, well, that's always risky. But I said, well, and this was an interested party meeting at a table just like this. There were probably 20, 25 people there with the representative and her staff that were planning to introduce this legislation. And we go around the table and there's insurance advocates and patient advocates. And I'm the only healthcare provider in the room. So I had that going for me. And I just kind of sat there and I wasn't really sure what to do. I just, smiling and nodding along. And then something happened. And the insurance lobbyist decided it was her time to speak up and challenge EMTALA. And again, EMTALA is what says that we have to see everybody. And she says, well, Dr. McCrea, I just don't understand that before you evaluate a patient, why you can't just check their insurance and make sure that they have the right insurance. And as Amanda probably remembers, I professionally lost my mind, right? I didn't yell, I didn't throw anything, I didn't swear, but, and it was a very formal meeting, like be called upon, raise your hand, recognize. And I said, I'm sorry, Representative, I can't let that go. And at that moment, I had something to say because I actually take care of patients every day. And I was the only healthcare professional in the room. I won't say her name, but the lobbyist didn't say anything for the rest of the meeting. And then we had many subsequent meetings with the representative after that, because I actually knew what she was trying to do, because this is what I do every day. And it always made me smile over the next year or two when Amanda would see that particular lobbyist. It's like, I saw your friend today. So again, you don't have to be an expert. All you have to do is be who you are. Be the medical student or the resident or the practicing physician, because you know so much more than you think you do, okay? Because all you have to do is show up and do our jobs a few times, and you know more than anybody else in the room does about what we do, okay? And again, if you're not part of it, someone else is going to make those decisions for you. So with that, I know I went a little long. I want to take time to see if there's any questions. I know there's a couple things in the chat, but I don't have 3 video monitors to see what's up there. So thank you so much for coming and giving up a Monday evening on what actually is a beautiful spring day, at least here in Northwest Ohio in Toledo. But I'd be happy to answer any questions if anyone has any.
Thank you so much, Dr. McCrea. It was a good hearing it again. Most of the comments in the chat are actually me making jokes.
Oh, awesome. I will look at them later.
I guess for our students who are on, I guess one of the questions would be, as a medical student, what is that kind of like going to the leadership and advocacy day down in Columbus?
So what to expect? I promise you won't go to a meeting by yourself. So don't worry about that. I can tell you a story about that. My first DC visit in a second. You'll be paired with any of us, and you'll be surprised that you'll be motivated to speak, especially if you come to the primer next week. Again, Amanda, sorry to put you on the spot. What are our issues for 2 weeks?
So we are talking in support of House Bill 99, which
Obviously.
is the prudent layperson
Right.
legislation that you highlighted. We are also talking about workplace violence. That's another proactive initiative that Ohio ACEP is working on. We don't have a bill number yet, but we're asking attendees to think of stories where you have felt threats of violence or have actually had violence directed towards you while working. And then the third item is psychiatric boarding, which you also touched on a bit in your presentation.
Right. So pretty bread and butter things that we deal with every day, right? These are not detailed billing code questions. It's just, we think people should be able to come to the ER when they want to. We shouldn't get hit while we're at work, and people shouldn't spend days, weeks, or even months in an ER waiting for a bed to get treatment, right? That's it. All right, that was the primer. Thanks for coming. No.
Yeah, Holly, why did we spend so much time and you put so much effort into making it a full page of talking points when it could have just been one bullet point?
Yeah. Politicians like one sentence, right? What's the elevator pitch, right? So yeah, similarly our issues in DC this year, workplace violence, just ED boarding in general, not just like boarding. And then, yeah, we did talk about a Medicare thing too, which did require some actual knowledge of what we were talking about. But it was pretty easy. We had a nice graph and it was very easy to explain. So that was helpful. I'll tell you my first visit I ever did. So when I was part of the Ohio ACEP Leadership Academy, I went to DC. It's one of the things that we have our academy folks do. And the person that I was supposed to do my visits with on Capitol Hill had a family emergency and had to go home. So I had to do my first visit by myself, and it didn't go great. And I mean this professionally. One of the most attractive people I've ever talked to in my life, and was just sitting there. It's like, so what do you want to talk about? And and she actually reached out and touched my hand and said, it's okay, you can look at your notes. So I promise it won't be that bad. But I regrouped and I talked about bill numbers. And then the rest of the day went better. And ever since then, I've figured it out. But yes, I'll still never forgive. I won't say who it was. Obviously, appropriately went home and thankfully everything was okay. But I was absolutely terrified. So I promise that won't happen to you. Even if it's not even if it's not my representative, I will come to a visit with you. And just help you speak, because they want to hear from you, because you're their constituent, because you can actually vote for them. What's even better is if you work or attend school in the same district where you live, right? Because now you count twice. Because not only do I vote for them, I take care of the people that vote for them, right? I don't wear badges on I don't wear a white coat anymore since COVID, but I don't wear political stuff at work. But every once in a while I'll talk about things. For patients, it would be really good if you contacted your congressman about this. I said that to a patient on Saturday for a billing thing. It's like, yeah, that's not fair. I'm sorry that happened to you. I don't know if she will or not, but maybe she will. So any other questions? We've got just a few more minutes. From either Addison or JC.
I thought that was great. Thank you. I was kind of also thinking, what would I have to say to somebody in an advocacy meeting? And then when that lobbyist attacked Ian Talla, that got my blood boiling as well. And I think
You're welcome.
Say.
Yeah, it's I often think when we have meetings, now I meet with the same people pretty much when we go, and they know me and I know them, and I meet with them outside of our once a year visit. But if we ever meet with somebody new, Representative Congresswoman Capter had a new staffer in her office and really wasn't that familiar with emergency medicine. If nothing else, and if I leave a visit and they understand I'm Talla and prudent layperson, that's a huge win for us, right? Regardless of what we're actually talking about. And obviously there's a way to say, so do you know what EMTALA is? Don't do that. Right. And just say, do you understand why we have to see everybody? And if they say no, it's like, oh, it's actually federal law. Oh, really? I didn't know that. Yeah, it's a thing. So, and that, you should be able to take care of patients regardless. We want people to come in, and it's great if I say, congratulations, you can go home and follow up with your doctor. I had a good story about that with Ohio Medicaid a number of years ago, meeting with their medical director, a physician. And I completely sandbagged her. Amanda will remember this. Ohio Medicaid was considering doing the same thing that Washington did. And I had just a few weeks before that, as I say, thankfully had not meningitis, but I thought I did. I'd had a headache and a fever and a stiff neck for 5 days. And I'm otherwise healthy, and I had no other symptoms. And 2 days before I got sick, I actually took care of a patient that had meningitis. Right. So I was pretty worried that I had meningitis. So I went in and I got evaluated, and my partner tapped me. Champagne tap, shout out Sarah. And my discharge diagnosis was, of course, acute viral syndrome. And so when I met with the Medicaid medical director, I completely set her up. And I told her the story of this 35-year-old male who came in with headache and fever. And she's like, wow, sounds like he has meningitis. I was like, yeah. And thankfully, I won't say her name. Thankfully, I didn't, after they did my spinal tap and discharged me and told me to follow with my family doctor. She's like, I get it. Right. It doesn't have to be actually your healthcare, but we have enough patients. It's even better if it's you. So you'd be surprised, Addison, even a month into clinical rotations, you already have stories. You just don't realize it. And all you have to do is tell them. And all you have to do is come. And I hope you'll be there. And JC, I don't know you, but I hope you come too.
Hi, thank you. I just want to say thank you for everything that
Well,
you went over with us. I'm actually going to be going down to Columbus tomorrow to see kind of what Amanda does and
oh, awesome.
get involved there. I'm pretty new to the little advocacy platform here, so we'll see what we can learn.
Where are you in your training?
So I am transitioning into second year EM resident.
Okay. All right. Awesome. Well, thank you for joining us. All right.
Thank you.
Anything else? We're right at an hour, so that went a little longer than I thought. I told more stories than I thought I would, but that's okay.
Thank you, Dr. McCrea. I'm going to go ahead and hit stop record.
Okay.